Welcome. This is the first episode of a new podcast, The Michael Rothman, and this is, in fact, The Michael Rothman. We will be talking about topics in healthcare, about data analysis, about saving lives, about efficiency, about return on investment, about various topics that affect hospitals, about topics that affect the continuum of care, about health, about life, and about other things. And what we're planning to do is create these small podcasts, maybe just 10, 15 minutes, to start a conversation about a particular topic. Some of them be controversial, some of them not so much. And we'll see where this takes us. I hope to inject a little humor along the way, and we may have guests. I know people in the industry, and it might be fun to get their opinions. One thing to make clear is the conversation, the opinions that are going to be presented in this podcast are mine. They may or may not reflect the opinions of Space Labs Healthcare, which is the company for which I work. Let me start a little bit with, for those of you who don't know me, and there may be some out there who do not know me, I have kind of a strange background for the healthcare field. That is, I have a PhD in quantum chemistry, not the typical medical school background, but I've been working in this field for 20 years, and I've worked with many doctors and many nurses, healthcare executives, entrepreneurs, the whole gamut of the healthcare field. And what I have learned, I think, could be useful if I shared it with folks out there. I've often thought when I attend a conference and I go to a keynote session, yeah, that's interesting, but I have things to say that might be even more interesting than the keynote speaker, but I haven't been up there yet. I've given lots of talks, but not a main keynote at a conference. Maybe after the Michael Rothman podcast has become wildly popular, someone will invite me to do that. But we'll just have to wait and see how that goes. All right. So what are we going to start this whole endeavor with? For the first topic of our podcast, I would like to talk about sepsis. I would say most people have heard of the word. Of course, the physicians and nurses and healthcare administrators are well acquainted with sepsis. What is sepsis? It's a systemic infection, typically an infection which is in your blood, and it can lead to very severe consequences. However, there are a lot of misconceptions. When you look into the literature, what you're going to find is that there are two facts which are repeated. And you will find this pretty much in every paper that you read. Unfortunately, these are misleading, and it has it has directed a lot of energy in this country in what is, in my opinion, the wrong direction, the wrong way to approach sepsis. So what am I talking about? The first fact is that roughly a third of hospital deaths are associated with sepsis. That is overwhelming. That's astounding. That means that hundreds of thousands or millions, I'm not sure what the number is, but there are many, many sepsis deaths. It would lead you to believe that if we had some way of addressing sepsis, we could save thousands or hundreds of thousands of lives. Certainly, that would be wonderful. However, you really have to think closely about what I said. I said a third of deaths are associated with sepsis. I didn't say they're caused by sepsis. Well, what's the difference? It turns out that most people who are dying, whose deaths are associated with sepsis, are not dying of sepsis. They are, in fact, dying of some significant, often chronic disease. They're dying of metastatic cancer. They're dying of end-stage kidney disease. They're dying of congestive heart failure. They're dying of complications related to diabetes. And yes, they end up with an infection. It's not surprising that many of them end up with an infection because as you die, one of the things which tends to happen is the failure of your largest organ, and that is your skin. When your skin is compromised, it becomes easy for bacteria to enter the system and to cause the systemic infection, which is described as sepsis. In fact, if you look into this very carefully, and people have, there was a study, and you'll see the reference later in this podcast. There's a study of 300 sepsis deaths at a number of hospitals. For that study, the physicians involved did chart reviews and really looked for what was truly the cause of death. Was it something which was driven by sepsis, or was it a situation where this was a patient who was in the process of dying and ended up with an infection before they died? What they found was that treatment for sepsis would definitely have affected only 4% of those 300 deaths, with another 7% saying treatment for sepsis might have made a difference. If you put those two numbers together, almost 90% of the deaths that were associated with sepsis would not have been affected by treatment for sepsis. Whoa. What does that mean when you talk about a third of hospital deaths are associated with sepsis? Well, out of that third, maybe it's 10% which are, quote, caused by sepsis. And the other 90% of those deaths were deaths that were inevitable given the terminal condition of the patient. So Yes, sepsis is important, but it is not responsible for 30% of hospital deaths, for a third of hospital deaths. It's just not. I said there were two facts. There's one other fact, which is, again, often quoted in papers on sepsis. And what that fact is that for every hour that you delay treatment for sepsis, there's an increase of 7% in the likelihood of that patient dying. Wow. Okay, that means you need to treat for sepsis right away. Well, first of all, we've already established that people are not really dying of sepsis, but some of them are. Okay, but let's go back to that 7%. That 7% referred to a very small subset of sepsis patients, those who have what's called septic shock. And if you delay treatment for patients who are in septic shock, where there is roughly a 50% mortality rate, this is a very advanced systemic infection, one that is overwhelming the body. If you delay treatment, yes, there are bad consequences, but that is not what sepsis is in general. In fact, in terms of sepsis, about 85% of sepsis cases don't develop in the hospital. They are present at admission to the hospital. A patient has pneumonia and they end up with some systemic infection, and they're categorized as septic when they get to the hospital. Sepsis is defined in various ways. The earlier definition of sepsis divided it into three categories: sepsis, severe sepsis, and septic shock. Almost all of those patients who arrive at the hospital with sepsis have sepsis. They don't have severe sepsis or septic shock. So when we're looking at the necessity for rapid treatment, we're talking about septic shock, and very few of those patients who have sepsis have septic shock. And very few of those patients who are dying associated with sepsis actually die of sepsis. So is sepsis important to look at all? Yes, it is. It is. And then it leads us to look at sort of the other side of the coin. What is the other side of the coin? The other side of the coin is you'll see headlines in the newspaper. Someone went to the hospital and died of sepsis. A person who is not in the process of dying, a nominally healthy person, goes to the hospital and dies of sepsis. It does happen. And when it happens, it is horrible. It is a tragedy. And sometimes it ends up in the newspaper. In New York State, where I live, there was a very sad case. A 15-year-old boy scraped his knee, ended up getting an infection, went to the hospital, was turned away from the emergency room, went home, came back a day later, was admitted, and died of sepsis. This had such repercussions that the New York State legislature passed a law requiring hospitals to search for sepsis, to scan for sepsis at admission to the hospital. There's a similar case, a little girl in Illinois, healthy girl, ended up also dying of sepsis. Her name was Gabriella Galbo, and in Illinois, they have a law called Gabby's Law, which requires screening for sepsis at admission to the hospital. So there are these cases, and I've heard personally of cases where a nominally healthy person went to the hospital. 3 days later, they're gone. So there is the other side of the coin. Yes, sepsis is important. Yes, you should be aware if your patient has a systemic infection. It is of great importance. But is it the lever that we can pull? Is it the place for our energy to reduce mortality in hospitals? I would say, based on the research that I've done and based on speaking to many physicians, that the answer is no. It's not the place where we should devote our energy. In the next episode of the Michael Rothman, we'll talk about, well, what is the right way to address sepsis? Or more importantly, what is the right way to affect mortality rates in hospitals? Mortality rates in hospitals are lower than they've been. Conditions have improved over the years, but they're still too high. Roughly, depending on the hospital, 1% to 3%, typically around 2% of patients who come to the hospital don't leave the hospital alive. About 2% of hospital patients die. And there are a lot of things that could be done to prevent that from happening. And even more important, I mean, you might think death is the most important thing to address, and it is a very important thing to address. But what about the 98% of patients who are not going to die in the hospital? Should we ignore them? No, we should focus on them as well. Can we improve care? Yes, we can improve care. So those will be some of the things that I'm going to be talking about in the next episode of the Michael Rothman. I hope you found this helpful as you think about sepsis, as you think about your sepsis coordinators in your hospital. But you really need next week's episode to get a better idea of what those sepsis coordinators should be doing, how best to invest the time of the doctors and nurses who take care of patients in the hospital, because directing their attention to the right patients at the right time is a very important task. So, with that said, thank you, and I will see you next time.